Hi, everyone. Thank you for joining. My name is Kristine Cigna. I'm an exact care clinical pharmacist and liaison to the VNA Health Group. Today I'm going to go over the collaborative medication management program we have in place here at the VNA. Throughout the presentation, we'll be referencing a patient case in which this intervention prevented a potential anticoagulant-induced hospitalization. So let's get started. Patient adherence to medication regimen is central to good patient outcomes. Adherence is the degree to which patients take medications as directed. Now, non-adherence can occur either intentionally or unintentionally and can lead to either underuse or overuse of medication. The primary hazard of non-adherence to anticoagulants is that underuse would not provide patient with enough anticoagulation, while overuse would potentially result in too much inhibition of clotting ability and subsequently increased risk for bleed. So when you're dealing with non-adherence and outcomes, you have to consider patient medication therapy and disease state. The consequences of non-adherence have been shown to drastically affect patient health outcomes. Non-adherence to medications is estimated to cause 125,000 deaths annually. And not only does it affect the patient outcomes, it's extremely costly. Research has found that patients with high blood pressure who are not adherent to their medications have more than 5 times greater risk of hospitalization, rehospitalization, or premature death. And diabetics' risks are 2.5 times greater for hospitalization when not adherent to their medication regimen. Keep in mind that research shows about 20 to 50% of patients are not adherent to medical therapy, and this includes non-pharmacological interventions like diet and exercise. The World Health Organization identified 5 interacting dimensions of medication adherence, and within each of these dimensions, there are factors that affect patient adherence. So for instance, lack of a support network or health insurance or common social and economic barriers. When you're looking at the health system or healthcare team, provider-patient relationships are critical in optimizing adherence. So relationships with little trust or poor communication create a barrier, and patients are less inclined to follow medical advice or be accepting to new medications. Complexity of medication regimen or cognitive or physical impairment are all common barriers that affect patient adherence as well. I encourage all healthcare professionals in any practice setting to familiarize themselves with these factors and bring them with them to every patient encounter. Although medication non-adherences occur in all diagnoses and demographics, there are subsets of the population who are at greater risk. So those who are on multiple medications, those with multiple chronic conditions and comorbidities, like heart failure, diabetes, dementia, complex dosing regimens, so not once daily dosing, but twice daily dosing, 3 times a day, 4 times a day, use of high risk or high alert medications such as anticoagulants, opioids, and hypoglycemics. And then patients with cognitive or physical deficits are at a greater risk as well. So our patient today is KC. She's an 80-year-old female, status post-DVT, being discharged today with the following prescriptions. I'll give you a moment just to look over them. KC does not drive, so she's asked her neighbor to bring the scripts to the pharmacy, have them filled, and then bring them home to her. KC also requests easy open lids due to her arthritic hands. Based on this information, ask yourself if there are any factors that may affect med adherence or if there are any potential concerns the patient and doctor should be aware of. Oral anticoagulants are one of the highest risk outpatient drug therapies with injury rates that can exceed 10% per person year. This information here comes from the QuarterWatch Annual Report, which is an independent publication of the Institute of Safe Medicine Medication Practices. In 2015 alone, the FDA received almost 35,000 adverse drug event reports related to anticoagulants. The major problem reported was hemorrhage, and the most frequent bleeding sites being the GI system and the brain and central nervous system. The actual deaths and injuries associated with anticoagulant therapy are unknown, but thought to be 10 to 100 times higher than those actually reported. Events occurred primarily in older adults, with median age being 73, and a quarter of the patients were 81 and older. This actually emphasizes how older adults taking these agents are at greater risk. Now, starting in 2010, there was a new generation of agents called novel oral anticoagulants that became available and were marketed as easier-to-use alternatives to warfarin. While warfarin requires biweekly testing and regular dose adjustments, these drugs are prescribed only in 1 or 2 dose regimens, so once daily or twice daily, with no therapeutic monitoring required. Since their inception, there have been substantial changes in the number and type of anticoagulants patients are exposed to. As you can see here in Table 4, from first quarter in 2014 through to fourth quarter of 2015, novel oral anticoagulant prescriptions dispensed rose almost 74%, with rivaroxaban being the most prescribed of these new agents. Now, although warfarin use declined by about 11%, it continues to dominate the oral anticoagulant market. So in 2015, the FDA received 1.2 million adverse drug event reports total. That included domestic and foreign, serious and non-serious reports. Manufacturers are not required to report foreign non-serious events, which is why they're not listed there. Of these events, there were 330,000 reports occurring in the U.S. that were coded with a serious outcome, which is defined as hospitalization, disability, or death. This is about a 10% increase in serious injuries reported from 2014. It's assumed or it's thought that this increase is due in part to the widespread clinical use of newer brand name drugs, such as the new oral anticoagulants, and then some of the new diabetes drugs that are out. Rivaroxaban accounted for the largest number of reported cases of domestic serious injury. This information, I feel, just reinforces the importance of improving medication safety with use of anticoagulants. Let's check in with Casey. Now, 2 days after discharge and receiving her prescriptions, she's open to home care services. At StarterCare, the nurse documents findings of the visit, so she completes a medication reconciliation. All the discharge medications are included in the medication administration record, the MAR, with the addition of aspirin and Vicodin, or hydrocodone acetaminophen, which was found in the home. In the patient assessment, the nurse notes that patient states she was given a prescription for warfarin in the past, but it was never filled. She demonstrates difficulties opening each of the pill bottles, even with non-safety caps, and requests that the nurse leaves all the pill bottles open, saying that she'll be able to manage. The nurse also found medications in one of the cabinets that the patient said she was keeping just in case. Again, with this information, what factors come to mind that would indicate the patient is high risk for non-adherence? Now, the VNA Health Group and Exact Care Pharmacy partnered to implement a medication management intervention. Our philosophy for this intervention is that it is a collaborative approach to managing patients' health. We believe an interdisciplinary model is essential in patient-centered care and is a driving force for enhancing medication-related outcomes. We leverage a highly communicative and interactive model between home health agency, physician, and pharmacy to close any gaps in care and promote safe transitions into the community. now, as the pharmacist, after the home health nurse completes start of care, I review the patient's medications and the medical record. I review the medications for any medication-related problems or concerns, such as drug-drug interactions, duplicate therapy, high-dosage therapy, and so forth. I also assess patient for any triggers indicating that they are high risk for non-adherence or medication mismanagement. So highlighted in red here, in the MAR, I identified duplicate therapies, Xarelto, that's entered, and an incomplete order frequency for the Vicodin order. From here, I create a pharmacy consult detailing these concerns, and then I send it over to the nurse case manager for action and resolution. After reviewing the medications, I go over the patient assessment, and it's here that I found factors that make her a potential candidate for adherence packaging. Now, this is where the exact care pharmacy comes in. So some of the triggers include inability or difficulty accessing the pharmacy, impaired dexterity, history of non-adherence. Per the patient's request of keeping all the lids off the vials, you can assume that patient engages in unsafe handling of her medications. And then, of course, the concerns of the fact that she received 2 doses of the Xarelto puts her at risk for overuse non-adherence. Now, in summary, now that I've completed a consult with the details and recommendations, I notify the nurse case manager, who will contact the physician and patient accordingly. She'll then obtain new orders, if any, and adjust the MAR accordingly. So the nurse also assesses patient for risk factors and educates them on the medication management program that's available to them, as detailed in my referral, and also the patient should be educated on the program at start of care. So our outcomes of the intervention. When the nurse contacted Casey, she found that the patient was, in fact, taking both doses of Xarelto. Patient was promptly educated on proper administration of the medication and was assessed for bleeding. The physician was contacted to inform them of the incident. So again, it's important that potential barriers for non-adherence are always kept in the forefront of our mind when we're interacting with our patients. In this case, the patient was unaware of proper administration of the drug. You have to consider communication deficits are common upon discharge from the hospital. The patient missed an opportunity for consultation at the local pharmacy because the neighbor went and picked up the medications. And although the start of care nurse confirmed the first dose of Xarelto for 21 days only, and the patient verbalized understanding, she was still obviously confused. That is very common, where patients will say that they understand and they actually don't. And this is because they often hide doubt or lack of understanding for fear if they ask any questions, it'll take away their independence. So always using open-ended questions and safe practices like teach back are very important when you're communicating with a patient. Now, because of the collaborative efforts between the pharmacist and the nurse, we were able to identify patient was receiving that duplicate therapy and able to intervene before a hospitalization occurred. Patient initiated the exact care service, and with that, the medications will be sorted safely into easily accessible dose packets for the patient to handle, so they're easy to tear open instead of having her handle vials. And it's delivered to the home, promoting adherence and continuity of care, so she doesn't have to worry about having someone go and pick up the prescription for her since she's homebound. Our program goals are simple. So we want to keep patients healthy and at home. With this collaboration, we strive to improve medication knowledge, medication adherence. We try to improve the med reconciliation process, reduce polypharmacy, and also reduce hospitalization rates of our patients. Again, we want to keep them healthy and at home. So some points just to leave you with. The pharmacist is part of the interdisciplinary team, promotes patient-centered care, enhances medication safety outcomes, and also is a drug information resource for the entire clinical team. Assessing patient for those factors that we discussed and considering adherence packaging as a potential intervention can promote positive patient outcomes when it comes to medication. And older adults are at greater risk for anticoagulant-related adverse events. So again, close monitoring, open communication, and participation in an interdisciplinary model with a patient-centered care focus all promote safe medication management and enhance patient outcomes. And I thank you all for your attention today. If you have any questions, please contact me. Thank you.